and then it's posted automatically if I just click on it or whatever. So I tried doing that on the weekend after the request, and there's some kind of, for some reason, I didn't have the right sort of priority or whatever to go in and modify it or save it or look at it. So I'm just going to do it on my computer today, and I will finish a little early and start uploading. So it'll be uploaded within 30 minutes of the class finishing. So, I mean, it was Yasser, and the principal problem was there was a delay between my uploading some of the previous lectures, which was inconvenient. So sorry about that. Today, I will make sure it gets started to upload before I'm walking away. And I can revisit this, trying to do the LTI Pro thing later when I get my various permissions modified. Okay. What was the other thing? Oh, for our assignments, in the sense of giving a presentation to the class, this Thursday, 2 days from now, I will give an example presentation so that you see an example. Okay, just like sort of the level of detail of a literature review if you're going to pick a paper and do that. I can also, if you wish, go back to previous years and grab some good presentations from students and post them up, if that would be helpful. So you kind of see the level at which those projects and presentations were done. I believe we probably will have about 15 minutes per presentation. I haven't done the exact timing yet, but it's going to be on that order, 15 to 20 minutes. And hopefully some discussion at the end. This is a chance for, the students to look at the material and say, okay, I want to do a deep dive on this particular topic. And it's very helpful to the class, and it has been in previous years, in the sense that you can sort of do 15 slides or 15 minutes on a smaller, focused topic. People have done MATLAB simulations, Python simulations, or just take a group of papers, like 1 to 3 papers, and show that it has been proven thus, so you can walk away with a sentence that is true, a declarative sentence that's true, and with some references to back it up. And this field is very interesting, comparative imaging, or comparative medical imaging, biomedical imaging, in the sense that there are many competing imaging technologies to answer the same questions. And there are competing economic reasons to do it in one scenario versus another. Right, in the sense that you either want to reduce cost of millions of people going down a certain pathway. That is rarely the case in North America, right? Mostly it's a European thing where you have state single payer systems where they're saying, how do we diagnose this particular disease most efficiently? And here it has a much different trajectory economically. And interestingly, the literature reflects that economic decision pathway, right? In the sense that it's rarely you'll see here where cost effectiveness is, they try and evaluate it. It's mostly just effectiveness, like what's your positive predictive value? What's your sensitivity and specificity of this test? It's very technical. And then the cost equation just sort of plays out in the marketplace. Do insurers pay for it? And that's basically how that side of it's done. Whereas when you're a single payer system and you have a finite amount of cash for a specific disease, and you need to know how to spend down that cash in the most effective way, it's a different problem, right? I had a grad student work on cost effectiveness for a particular test, and this was calcium scanning, where you take a CT of somebody and you look at calcium in their coronary arteries and you decide whether or not they should go further down a testing route. And, between you and me, that, like, we looked up and she learned all of this stuff about cost effectiveness. it is hard. It is so hard to do that correctly, because at each bifurcation of a patient, whether you say, okay, this test is positive, the probability of it being positive and the probability you're right on that call bifurcates the patient down these two pathways, that tree becomes hopelessly complex very quickly, right? And so you have all of these possibilities occurring. You need to know the coefficient of accuracy at each one of those nodes, and that thing becomes horribly untenable, right? And so there's a good reason why people don't do cost-effective research, is that the answer oftentimes I would say is just the best guess, right? You know, it's really not a something that's easily done. So, however, for us to evaluate these imaging technologies, you have to ask, well, what is it we're trying to evaluate? In the end, you want to know, does the test produce more information about that patient than you already had that will significantly change their management? Like, there's got to be a high probability that if you do the test, you will make a correct decision at this management decision. So this one node. And that's quite different than what is the spatial resolution? What is the point spread function of this imaging system? What is the time resolution of this imaging system? As engineers, that's the stuff that we do. We can do that stuff easily, and you can say, oh, I can make this image that's twice as good as this one because my spatial resolution is twice as good. Then you put it into the clinic, and it might not, right? And so we'll see today, we're going to do, in our nuclear medicine applications, we'll do cardiology today. Thursday, we'll take a look at cancer, right? And how nuclear medicine has really changed, you know, how people are treated in cancer. And then on Thursday, I'll probably do an example presentation. So as if I was a student and I'm going to present a paper, and I'll probably present either FAME2 or ischemia trial, one of those two. Heavily image weighted on evaluating imaging. So today we're going to look at nuclear medicine applications in cardiology, because that's, as we saw from the data, there's like $2 billion a year spent on this imaging test. Is it worth doing? You know, the single photon emission computed tomography of the heart is one of the most common imaging things done, other than a chest X-ray when you show up at the hospital, or your CT when you show up at the hospital. Okay, so let's start here. Any questions from you guys online or guys here about the project? You had a specific question.
Just like past recommendations for the segmentation.
Right. So the question is, do I have a recommendation for a specific segmentation problem that you could attack with deep learning?
Yeah, like I saw a brand new data sets.
Right. There are many MRI data sets online because the history of deep learning and segmentation is heavily weighted towards MRI, because there are many more people in MRI research, right? So if you go to the annual MRI meeting, there's 5,000 people there, or 6,000 people. If you go to the annual CT meeting, there's 500, right? If that, there's 200 somewhere. So there's a lot of people doing MR, and they have made these very large data sets. UK Biobank is going to have MRI on, like, you know, tens of thousands of people. MESA has MRI on a lot of people. And so those data are often available in a subset online for a challenge. So if you look at various meetings, they'll have these segmentation challenges, and different teams will put it. So oftentimes you can get those without any kind of permission, because they're completely de-identified. They're in some kind of file format that doesn't have any patient information in it. So you can look at any of those, and maybe even do the challenge, right? The specific challenge will have, you know, instructions written out. And then for us, you know, in this course, nuclear medicine has a, you know, this obvious problem with nuclear medicine is the resolution is so low that you could get truth information about what the heart is if you have CT and nuclear medicine, because the CT is done for attenuation correction in almost every patient. And then you have the nuclear medicine scan. You say, well, if I measure, my myocardial mass on the nuclear medicine scan, does it, correlate at all with what's measured on the CT, which is very accurate, right? So that's one possible thing. In our lab, we could give you data on cardiac CT, which, I have a lot of volume CT scans. And so if you wanted to test segmenting the myocardium, which is still an open problem in imaging, you could try doing that. The myocardium is tricky because, as we'll see in these pictures, to get the outer wall of the heart, it sits right on top of the liver. So your heart is kind of pocketed into this place on your diaphragm, and it slips around on there, and it's sitting right on top of the liver. The myocardium and the liver usually have exactly the same signal level, right? Especially on CT. And so it's just a continuous signal. There's no boundary. The reason that a human being looks at it and sees a boundary is they continue the boundary that's in the lungs and on the anterior wall, and it looks like a circle. You go, oh, well, it's a circle. That's where that boundary would be, right? But then when you go ask a human to go in and draw that boundary, the variability is quite high because there actually is no boundary there. So that's where something like deep learning, where you teach the network to draw that boundary, is quite useful, because at least you get the same boundary every time, right? You've got one observer, you don't have like 6 of them. And so if you wanted to do that, that's a pretty cool problem, right? Doing it in 2D is manageable. Doing it in 3D is a challenge, right? If you wanted to say, oh, I'm going to do this 3D segmentation at full resolution, that's not going to fit on your graphics card, right? So you have to do something like reduce the data set size by smoothing or something. We can talk about that too. So I got some questions here from Igor. Are we doing the project presentation individually or in a group? I believe it'll be a combination. Here, let me get this up on the screen too. In that, if you have a specific project that you really want to do and nobody else wants to do it, then you could do it individually. But it's probably more fun to do it as pairs, right? So that you can bounce ideas off each other. So that's my recommendation would be probably find a partner. There we go. Okay, great. Does that answer your question? The answer is it depends, on the topic. I will this week start organizing a lot of papers in a folder that are possible topics that you could review, and you're welcome to propose topics that you want to do, just like this. Yeah.
Okay, so I think I came in a week, so I didn't find where the project.
Oh, it's not up yet. Like the actual assignment, there's only 2 assignments up right now. One's homework 1 and homework 2 under assignments. The project will be up this week. Okay. And we'll figure out a way to get a partner if you want a partner, and we'll start looking at a schedule and a whole list of possible topics. The other thing is, I said earlier that I could possibly post project presentations that have been done by previous students that received good grades and were considered to be good projects. Okay. So that should be up by the end of this week. Sure. And no problem. Okay. And then I'm going to try and finish a bit early so that I can generate the .mp4 file and get it uploaded, in an hour or something after the class. Okay. Okay, any other questions? Over here. What is this? Command L for laser, that's right. Pen. What is it for the, okay. All right. So just as an introduction to what we're imaging with nuclear medicine, again, this is a, an anatomy book drawing of the heart and its major vessels. This is called the anterior wall. This is the wall you would see if you cracked open the patient's chest and you look straight down. You would see this wall of their heart. It's, towards their chest. And the major vessels that we're concerned with are, they come off the aorta, which is here, and one is the right coronary artery, which goes around the right ventricle, which is here. It feeds the right ventricle from these vessels, and then it goes all the way around the back of the heart to the posterior wall and drops down and feeds the back wall of the heart. Okay. When you're developing, both the right coronary artery drops to the back and the circumflex artery goes all the way around the back and drops down here. And then as you develop as a fetus, one of those systems wins out. The other one kind of dies away, which is a missed opportunity, right? You should keep them both, right? I don't know why that happens. It doesn't happen in many species. Many species have a lot of what's called collateral circulation, in that you're fed by, one piece of tissue is fed by two systems. So if one system goes down, the other one's there, and you don't die. Canines have particularly well collateralized hearts. Pigs do not, humans do not, right? So actually, if you're doing animal simulations of surgery and things like that for cardiovascular stuff, porcine things, although now in medical schools, it's amazing. They've almost every major medical school has done away with animal surgery training and stuff like that, which I don't know if that's a good thing or bad thing. I'll just leave it. But all I know is if somebody's cracking my chest, I would have hoped they'd done something other than on a computer. So anyway, these are the major vessels. This is the right. There's the left comes out of the aorta here. All right. And then it breaks into the left anterior descending, which goes down this way, and then the circumflex, which goes around the back. And so you have basically these three major pipes feeding your heart muscle the blood it needs for each contraction. And it's working pretty hard, right? So what happens in cardiovascular disease is the vessel itself starts growing this plaque, it's called, on the vessel wall. And that narrows down the channel through which the blood can flow. And just like a garden hose that you pinch, right? Depending on the upstream pressure, if the upstream pressure in your house is low and you pinch the hose, you can actually reduce the flow quite a lot, right? And so it can reduce the flow depending on how much flow you need, right? And this is called a total occlusion. This is when the lesion basically grows such that it shuts the vessel off. And that's a terrible situation to be in. One of these major vessels shut off. And then you can have this situation in which you have a very small amount of blood flow going through, but it's not lethal, right? So you'd like to know, actually, when you're my age, I'm 62, right? So I would like to know what my vessels look like, just out of curiosity. That is a terrible way to practice medicine because it often leads to doing procedures that are unnecessary. Like I could have lived to 95 and never worried about it. But if I go and get it imaged and I see these lesions in there, I go, oh, well, maybe I should pay attention. Maybe I should take a statin and things like that. So it can modify behavior. But you certainly don't want to do it with an imaging technique that is half the time wrong, right? Because then you're just throwing noise into the situation. So what happens when the vessel closes down? for us in imaging, we could either image the lesion itself and see it's there. You can also look downstream of the vessel where you have this block and look at the myocardium and ask, is that myocardium different? Because it's low, it's getting low blood flow. It will change, right? And it'll change in a number of ways. If the blood flow goes down low enough, you'll get contraction abnormalities. The muscle will stop contracting fully. It'll shut that down first. You'll then get electrical abnormalities. I think we have a table here, yeah. So this is myocardial perfusion on here on, say, milliliters of blood per gram per minute in the myocardium. That's what the units would be here. Excuse me. And then this is a bogus plot, right? Signs of ischemia on this axis. So as the perfusion goes down, you start seeing these things happen. So the first thing that happens is you think you could measure, if you could measure the blood flow, you could measure a reduction and say, okay, we've got a perfusion deficit problem. You start getting the cells themselves start metabolically changing in order to survive, right? So they're low in oxygen and they have to shut certain systems down in the cell to survive. You start getting motion problems with the heart in that it starts relaxing more slowly, right? And it starts contracting more slowly and perhaps contracting less. So the muscle itself, when it used to contract to, say, from a unit of 1, it would contract down to a unit of, say, 0.65, right? That contraction would occur. It now only contracts down to 0.85. And so you get a reduction in the systolic contraction. You can image that, right? And we'll see examples here. Imaging plays a role in looking at these actual dynamic contractions. Late in the game, you start seeing electrical abnormalities in the tissue in that the cells themselves are trigger cells. They depolarize, which they open channels and then ions like flow into a certain level. And that's the signal that tells the mechanism of contraction to start. And so that depolarization can shut off, right, in certain cells. And so the cell now, it's just a neutral piece of tissue. It's not really activated anymore. You can actually see those electrical changes when you map the voltage on the surface of the patient. You take a picture of, say, the voltage difference between, say, here and everywhere else on the chest. And if you visualize that voltage difference as a scalar or color map, that thing evolves over each heartbeat. And you look at that map, it's a type of imaging where all your sensors are just like electrodes on the chest. And you watch the ECG changes, right, as the patient is going through, say, a heart attack, and you'll see quite fundamental changes. And we'll take a look at that. Late in the game, people get pain. So when they show up at the ER and they have shooting pain down their arm, or they have really bad pain in their jaw and their neck area, and they feel sick, and you strap an EKG lead on them and you look at it and it's abnormal, no imaging necessary at that point, right? That person is pretty well going to the cath lab, right? Because they probably having a heart attack. Back here, imaging is usually necessary. It's like, is this, indigestion? 75% of the people that come to the ER with pain and classic symptoms of a heart attack, other than a big STEMI on their ECG, if they have a normal ECG, but they have all this pain, 75% of them are absolutely normal, right? So you don't want to send all those people to the cath lab. You need to look at them with imaging and say, okay, who's going to the cath lab? Who are we sending home with a pack of Rolaids, right? Say, call us tomorrow. So imaging with these delta voltages, classically you put a lead. This is just it's a gel with a piece of metal going into the gel. It goes on the skin, right? And you put one on each arm and one on a leg. And that's all you need traditionally, although we'll see it gets ramped up. And you measure the difference between the voltages between these points, right? So there's no kind of absolute voltage with respect to ground, like what is ground, you know? So it's a delta voltage across the patient. Right? And then when you can look at the center of mass of that, you know, difference map and put that in the middle, and you can measure the difference of these leads to that center of mass. And these are 6 independent, well, they're not independent, 6 signals, which are obviously dependent, right? These ones are dependent on these ones. And you map them out and take a picture of that patient's voltage maps. If you're doing what's called a 12 lead EKG, and if a patient shows up in the hospital, they usually do this, they put another set of leads, another set of 6 leads right across the chest above the heart, okay? And this is increasing the spatial resolution of this imaging technique right in that location, right? We're gonna look at, you can think of this as a color map on the patient, and we're putting these leads down to look at the delta voltages between each lead. And now we've got very high resolution imaging here for this type of imaging. And the function itself is a pretty smooth function, so you don't need super high resolution to image it. All of the voltages are actually generated by voltage differences on the surface of the heart, right? And those voltages project through the tissues out to the surface of the patient. So the actual source of the voltage difference is this, you know, thing about this big in the middle of your chest. You would like to have a really nice voltage map on that object. But what you get is whatever happens when that voltage projects out onto the surface of the patient. That's what you get. So it goes through a whole bunch of tissue and it gets blurred. But you can do an inverse problem to try and project it back onto the heart. A really good physician doesn't need the inverse map as a picture. They look at this. And this is a set of those voltage differences on the patient. And to read this, this is lead 1, lead 2, lead 3, AVR, VL, VF. And then these are the 6 leads across the heart. And we're showing it here for 2 beats. So there's 1 beat, 2 beats for this lead, okay? This is called a QRS. It's PQRST is this one here. And I'll show you a blown up diagram of that. This is the depolarization of the heart, which tells it time to contract. And then all of the left ventricular muscle will contract. The reason the voltage is high is it's because it's the whole bulk of the LV and RV muscle is depolarizing at that time, and it makes a large voltage across it. And then it sits quiescent as it's, you know, contracting and hits end systole. And then there's another pulse, like voltage pulse, when the heart relaxes. Okay, and that's the T wave, and that makes this pulse here. And so a really good physician, or any cardiologist worth their salt, can just look at one of these and almost instantly tell you what's going on, you know, in the heart. And you know, the cardiologists I work with here and those at Hopkins, sometimes you have friends or whatever, and they give you one of these strips and they say, you know, I got this from my cardiologist and he said it's the following, can you have somebody look at it? So that's it, right? You just get this. And so you walk down the hall and one time I walked down the hall to Ron Berger, who's at Hopkins, and I said, Ron, my neighbor has this. Like, what would you call that? And he goes, oh, you know, that's a outflow tract, such and such. And he goes to his desk. He had like a filing cabinet that had about like 12 filing drawers there. And he goes, oh. And then there's like 150 files there. And he goes, and he pulls one out and it's identical. Yeah, like, okay, so that's actually in your brain, right? So he's like a deep learning unit that's just trained on all of these cases, right? And just can map this picture, these, you know, basically 12 lines to that patient, to that thing. So you wonder, like this is like imaging, right? Because it's spatial and it's temporal. Like deep learning is going to do this, right? There's no question about this. I mean, Ron probably did 50,000 patients or something, right? But deep learning could do like 500,000 patients. You know, so you could take the whole UK biobank. There are so many of these strips in the world and outcomes of patients and stuff like that. So I think the days of that shaman probably will, you know, become that shaman with the sidekick, right? And the sidekick is like a resident who's seen 500,000 cases, right? So it doesn't nail the diagnosis, but it's going to get you very close to a bunch of patients who have the same thing. And it's small data, right? You know, it's a tiny data set. So here's what that data looks like up close. And it's a P wave. This is the depolarization of the atria on the top of the heart. And then there's no voltage difference across anything. And then there's this big depolarization pulse when the left ventricle and the right ventricle mass depolarize, causes a big voltage across them. And then during this time, the muscle is contracting down. And then right here, the muscle relaxes and you get this repolarization wave as the cells repolarize. It's just PQRST. This segment here, in a normal person, has no voltage difference across the heart, right? It's in this state. If you see this, when you strap the leads on the patient and you can see this, you know, most of the time I would say when you're looking at all these cases, these ST elevation things occur on the precordial leads, these chest leads. And so you've imaged across the heart and you see that the voltage never comes back down to zero. Right? There's always a constant voltage on or different voltage difference across the heart. And the way you generate this is you just take a patch of myocardium and make it not depolarized. So you've got an object and there's this chunk in it that is like basically it's not conductive, it's not depolarizing, not active. And you get this strange voltage that maintains across this time period. And this is called ST elevation. And this is a classic sign of somebody who's actually having an active heart attack. And if somebody shows up in the ER and they have this EKG, they don't waste much time, right? They don't send them to imaging to see, let's make sure this is a heart attack. This is called a STEMI, and it's basically a ST elevation myocardial infarct. And infarction means the tissue itself, the perfusion has gone down to such a low level that the cells themselves are dying. And so they're just, you know, and it can happen in a small patch, a big patch, or whatever, and it causes pain. And usually at this point, it's called activating the cath lab. It's like pushing the button on the wall, like ting, and the call goes out. And who's ever on call, whatever physician's on call, jumps in their car, it doesn't matter what time of day or night, zips down to the hospital, right, and gowns up, because you go in here and you want to open up whatever blockage is causing this, and you want to do it acutely. You want to do it right now. Don't wait. So here's an example. There's a review of the leads and what they look like. Here you can see on these precordial leads, big inverted QRS, and then a huge ST elevation, right, from V1 all the way across the front here, right? And then it's got an inverted T wave in V4 here. And so all the way across. So that would say it's probably an anterior wall problem, because it's these leads that are seeing a weird voltage difference versus the ones around the back. And then when you get the patient into the cath lab, and we'll look at this type of imaging, this is just real-time X-ray imaging. You inject a contrast agent into the vessel and see where it goes. it is getting through a tiny little channel here and going down to this distal vessel. That's the good news, right? Terrible news would be it just stops here, right? And then no blood's coming down here. However, what's happening now is the flow through here is at such a low rate that it's causing this ischemia in the tissue. So here the imaging just nails it. Like, what do we do next? Well, we open that, right? And so here temporal resolution is important because these vessels, when you watch the movie, they move with respect to each other, and you can see, like, in particular what vessel we're interested in. Spatial resolution is also very good in this on the in plane. Remember, we looked at this, it's like down on the microns level, like tens of microns, to see, you can see just a thin sliver, right, of blood getting through there. And then you use this imaging in real time to actually insert a catheter and a guide wire into this little sliver, right? So the physician now can use these images in real time, and they'll push a wire down in here, and then they'll like slowly push it through that lesion. So this is called cardiac cath. It's basically planar X-ray. It's very simple, but it occurs, you know, at upwards of anywhere from 15 to 30 frames a second. Right? And we looked at that in the introduction. We'll do it towards the end of the course. We'll look at cath. This is what the device looks like that you guide with that imaging system. It's made of a metal guide wire in the middle and a plastic tube or catheter on the outside. And so the guide wire can be, you know, pushed through or withdrawn from the plastic catheter. And then on the plastic catheter is a balloon, right? And the balloon, and on the outside of the balloon is a wire mesh, and it's been crushed down, right? And so the whole thing is pretty narrow. So the whole thing can go in. So usually you put it in a patient's groin, in a major artery in their groin, and you bring it up the aorta. It curls up around and approaches the root of the aorta from the top. And then you rotate it and engage either the right coronary artery or the left coronary artery. And you do that under image guidance. Okay, so you're watching the screen, you see where your catheter is, you rotate the catheter to get it pointed in the right direction, and then you push a little harder, and then it plugs in, right, to one of those big coronary arteries. And while doing that all the time, the patient is monitored very carefully. They can be conscious while all this is occurring. And they can tell you if they're in pain or not. Like if you induce more ischemia, they can tell you, that doesn't feel good. They can't feel this because there's no sort of, you know, tactile information in your heart, right? But then you push the guide wire down the coronary and you cross the lesion, and then you move the balloon. It has markers that are seen on the X-ray image to put it in exactly the right location, or you hope it's the right location. And then you inflate the balloon, and it basically dilates what you put in here is saline, right? It's just fluid, and it dilates it up to a certain pressure, and the pressure is measured. And you just like get it up to a certain pressure and just leave it there for a little while, and then bring the balloon back down, suck the fluid out of the balloon. And this is your condition after that, ideally. And you withdraw that device, or the guide wire and the catheter and everything come back. And what is left there is this stent. And the stent just holds the vessel open, yeah?
You look at time, which, and there's like what,
The blood is cut off while that balloon's inflated, right? Yes, but it's in the, you know, tens of seconds to minutes, right? So you can, for example, you take an elastic band and you wrap it around your finger and you occlude all of the blood flow to the tip of your finger. The finger's not going to drop off in 20 seconds, right? It takes a while for all this to occur. So, however, when you do this, sometimes the patient will say, oh my God, I feel a lot of pain, because you've taken the perfusion from a critically low level to 0. And now the ischemic cascade is going on. Interestingly, the riskiest part of this is when you take the balloon down, right? Because you get this inflow of blood, right? Which this tissue has not seen that much blood in a while, right? And there's just this rapid inflow of blood, and then the cells themselves sometimes do not react well. They themselves electrically start firing in weird ways, and you can get ectopy at that point. And so you'll get some electrical abnormalities as you feed fresh blood into this tissue. And so it's a tricky moment, right? Everybody's ready. You let the balloon down, and then you hope the person goes back into sinus rhythm, right? And if they don't, at least you have a catheter right there, and you can inject an agent that settles the tissue down in terms of its electrical activity. You just like attenuate it a bit, right? Try and get them through that, because what can happen is you get into this recurrent electrical problem and you shock the patient out of it. They'll be stable for like 10 beats and then boom, drop back into this electrical problem. They shock them out, and you don't want to get there if you can help it. Yeah. Did you have a question?
Yeah, I was going to ask, did the stent ever removed?
That's a great question. There's a whole industry in making stents, obviously, like not a small industry. This is a huge business. And stents in the early days started out as just steel mesh wires, right? And it was found when you leave a chunk of steel mesh wire in a vessel, you get, a biological reaction to that, which is, you would like the endothelium to just grow around on the inside of the stent and just make the inside of a perfect vessel, right? That did not happen with steel stents, in that it continued to grow tissue on the stent like a scar. Like if you had a splinter that was in your body, if any of you had a splinter in there for a long time and it grows fibrosis around it, the same deal, right? Just this fibrotic tissue grows around it. So, and that was an acute effect. Not only that, if there's an exposed piece of metal, it can kick off the thrombotic cascade. So if you cut yourself, you don't continue to bleed forever, right? Your body knows, oh, I've got this problem right here. I'm leaking. I'm going to start clotting blood right here. And so the blood clots up, and you get basically a glom of sort of spongy blood there that clots the tissue. That can happen here too. And that's really bad. So then you get this thrombotic response, which is like an exponential cascade, and it just and the whole thing fills up, and it clots off again. So the second generation of stents, I was at Hopkins when people were doing this, like just in their lab, they were like dipping stents into drugs, right, and letting the drug crystallize on the stent, and then they would do it again and let more drug crystallize on the stent, do it again. And that led to a bunch of patents and the whole industry of basically stents that had antithrombotic drugs coated all over the stent. And so for the acute phase, before you endothelialize around that stent, you had this antithrombotic drug there that would stop the thrombus. And that changed the complication rate in stents a lot. That was a big deal. Then you can have ones that dissolve, right? And so you put it in, it holds the vessel open, you get a new endothelial wall of the vessel inside the stent, and then the stent just dissolves away. That would be kind of the ideal situation. That turns out not to be used as often, I would say, as the others. So, but you can see here in 2010, this was done 2.3 million times in the US. Right? This is a big procedure. Costs, I don't know, $5 grand or something like that. And because you have a whole team, in the cath lab, you have a very highly paid interventional cardiologist doing the procedure, and the equipment itself is not cheap, right? So they'll say, oh, I need a such and such catheter, and they walk over to a cupboard, they type a number, which records what equipment is being used during the procedure, so the billing gets it. This thing comes and opens, and they take it off the shelf and go, pull it out, give it to the, rinse it or whatever, give it to the doctor, and that's another $4,000, right? So it just can add up. Physicians can get pretty good at knowing, okay, for this type of case, I'm going to use this sequence, and that's the most efficient way to get this done. But when things start going wrong, all bets are off. You just use whatever you've got in the cupboard to try and get things going. So these are pretty common procedures, and they are reasonably expensive. There is no question, if you show up at an ER and you have a STEMI, so your ECG has that abnormality, you have pain, then this procedure is life-saving. That is indisputable. I mean, you just look at the evidence for people who get what would be, suboptimal at this point care, and they don't go to the cath lab, or for whatever reason, they don't go to the cath lab. And you look at the people who go to the cath lab. The people that don't go to the cath lab die more frequently, and that's been proven many times. That's for a STEMI. The big question, and we'll look at this, is like, okay, so now I go and I've got all this really inexpensive, wonderful, non-invasive imaging, and I go and I get an image, and I look at my vessel, and oh my God, I've got like a 90% stenosis, but I feel okay, right? So you're sort of a stable angina person. So should you open that vessel? Like if you are like my age, you're 62, you go and you see in your left anterior descending, the main vessel down the front of your heart, and you look at it on the image. It didn't cost much money or anything, and it's really accurate. Well, the engineers have made this beautiful scan, which has happened now. And you look at it, it's like, oh, gee, that's a 90% lesion in my LAD. What should you do? What would be the common sense thing to do? So you're going to make that decision. There's no right answer. Huh? I would, yeah, exactly. My first thing, I was like, oh, geez, open that thing, because I can have this situation. That seems a lot better, right? It turns out that's not true. It turns out it doesn't matter. If you're stable and you have that situation, right, then if you do the optimal drug therapy versus getting this intervention, those two groups survive at the same rate, which is counterintuitive to me, right? Therefore, I would still get it open. I would go for the open. But when you do big trials, and we'll see this, like of 10,000 people, and you look at the rate of events subsequent to detecting that on this beautiful image, the rate of events in the people that get the stent and the people that don't is about the same, right? And it's remarkably low, and the reason it's remarkably low is because of really good drugs, right? So as long as you take your drugs. So here's what it looks like prior. This is an example of a person who came in probably with a STEMI, and you can see this vessel. It's kind of a mess, right? All the way down the vessel, in that this is supposed to be a smooth tube, right? And in a normal person, this is nice and smooth. Here, it goes down to this tiny little channel right there, which you can adequately measure, right, to estimate what the severity of the disease is. The imaging is good enough to look at this and say, that's a 90% stenosis, right? There are these classes of stenosis. So this is a severe stenosis. And then these are less severe, right? They're this one, you know, there's obviously irregularities, and somebody looking at this, making the report based on the image would say, you know, very irregular RCA for its full course, critical stenosis at mid RCA. Okay. So all of that engineering, all of that signal to noise, all of that spatial resolution comes down to that person saying those 14 words, right? And getting it right. And so you go in there and you put a stent, and you can see it's a little darker all the way from about here to here because of the metal in the stent that attenuates X-rays. But it looks like the best part of the vessel now, right? It's got a lot of blood going through it and everything. So I don't know, it's remarkable to me that leaving this patient alone, you know, if they don't have, again, there's no ischemia going on and they don't have STEMI and stuff like that, that they would do just as well as this patient. But that's what the data says. We'll take a look at the data though. Just because it's published and in a paper, even with fantastically, you know, responsible authors, does not mean it's true. Okay, it just means that's the data. So you have to. So here's a way of imaging how much blood is getting to the tissue that is ischemic. Okay, so ischemic tissue gets less blood than the normal tissue. And two ways of doing this. This is what we're studying right now, which is nuclear medicine. This is as a control for this patient, it worked out beautifully. They injected a contrast agent while doing a CT of this patient. So they're doing CT imaging, mostly to look at the vessels usually, as opposed to how much blood is getting to the tissue. But you can see what's happened in this patient. The tissue here in the left ventricle, this is the septum, this is the free wall. Up here is the left atrium. Blood comes down into the left ventricle. So now you know it's also going out of the left ventricle into the aorta and down the coronaries. Okay, so it goes from here out and then down into the coronaries. And that usually takes a couple of heartbeats for that to happen. Once you see this light up, the coronaries will light up in about 2 or 3 heartbeats. Right? They'll be full of contrast. And the tissue that the coronaries are feeding will also reflect the fact that there's contrast agent in the tissue, right? It's usually in the blood vessels themselves in the tissue, as opposed to diffusing into the tissue itself. It remains in the blood vessels, but it's in there and it's causing a change in signal. This piece of myocardium here, or looked at from a different angle here, looks distinctly like the contrast did not get there, right? So it's a really simple, you know, imaging task. It's just, did it get brighter in that location? And you can see you don't really need super high resolution to make that call here, because you've got a big chunk of tissue that contrast did not get to. So this is a really easy patient to diagnose. You got a lot of ischemia here. And then the nuclear medicine scan, and let's recall how we do this. We inject the patient with a radionuclide that is going to give off 140 keV photons. I'm going to lay the patient down and put that detector with those parallel beam makers around him, and just take multiple views and make a 3D image of that. So the patient's glowing. It turns out that their heart is glowing more than the surrounding tissue in the chest, which is really good. And you can see the septum, the free wall are glowing pretty brightly, but the apex, obviously relative to these, is less, right? And then in the short axis view, this is the same patient probably, it looks like most of the wall is normal in terms of the amount of stuff, and this is down. And again, we have this. So that's kind of a slam dunk SPECT scan where you say this person has a perfusion abnormality, it's quite severe, and it extends over these regions. And we didn't really need high spatial resolution. Remember, this spatial resolution is really low, right? The full width half max was centimeter or something. It was a big chunk of tissue, but we didn't need it. And so that is, why this technique took off really in popularity is because unlike other imaging techniques at the time, it could measure perfusion, right? And the agent that was used would flow into the tissue just under regular blood flow conditions. Let's pay attention just to the top part of this for right now. In particular, these two rows here. And after CT, we have a CT image of this patient through the chest, and we're going to do attenuation correction such that we correct for different directions, having different attenuations. There's a stress part of this test, and then the rest part of this test. And the stress you can induce with a drug, and we'll take a look at how that works, or you can make them ride a bicycle. And then afterwards, you let their heart come back down to its normal heart rate, and they're not breathing heavily or anything, and then you have a rest scan. And this can be done with a separate injection. So under stress, if we look at this is called a bullseye view of the heart. It's like looking at, if you took the heart out and you looked at from the apex towards the base, so from the patient's feet towards their head, and it's shaped like a bullet. And so the apex is right in the middle, is this point. The patient's chest would be up here, right? And the lateral wall, this is the patient's back, and this is their septum. This is called a bullseye view for obvious reasons, because it looks a round bullseye. So the apex here, this is the LAD region, or the left anterior descending coronary, feeds this. Basically, the major vessel, the circumflex vessel feeds this, and the right feeds this. And you can see there's this dropout right here. So this patient would seem to have in this position low perfusion, right? And this is under stress. After you allow them to recover and rest for a while, you take another scan and the heart looks like this. So what that means is, relative to this, the rest of the heart, this looks pretty normal at rest. That's because, let's make the numbers simple, at stress, the average amount of blood flow to each, cc of tissue might be like 4 mils per cc per minute at stress, right? Down here, it might be 1. So all of these are 1, and this can make 1. This part here that's ischemic at 4 turns out to be okay at 1. So it's at rest, you're okay. Yeah.
So the images have different averages, so the color maps from top and down, they're not the same, right?
The what maps aren't the same?
Color maps, so basically.
Oh, they're different. Yeah, they're normalized.
Why don't they use like the same? It's like there's a big difference. Like visually.
Yeah, it just visually it adds a dimension of complexity that, because everyone has a different baseline for one thing, and so you would have to become much more experienced at that. When you normalize it, it kind of speaks for itself, the data, right? And you just, you see this relative change. Now, to your point, this is a purple color, but I don't know, maybe that's enough flow. Maybe it's 2, and that's enough, right? But it is different than the rest, right? As engineers, this is what engineers always do, right? They say, well, a better thing, rather than these relative maps, would just be, give me the number, right? So if I ask you, like, what's the flow here? You would give me the number, and it would be 1.5 mils per gram, right? And engineers get really stoked about doing that, and they do that. I think I might actually have it here, yeah. So here's from nuclear medicine, right? You basically have a rest scan and a stress scan. And in each segment, you look at a temporal sort of evolution of the brightness as the injection occurs, and you just generate a map that the number gives you the flow in that region. Right? That seems to be a really sensible idea. And engineers love this. This is done though using PET, and it's done with an agent. I mean, the unfortunate notation here, this is H2O, but it's O15, right? As opposed to O16. And so it's a positron emitter, and it's water that can go anywhere. And so you can measure these perfusion curves. And we'll look at this when we look at PET, but just to address your suggestion. And, at that point, you should be able to claim, well, if I have the actual number and I know what the critical number is before I get ischemia, then that should be the way we do this diagnosis. And if you have a PET scanner, yeah, you can do that, right? And you can see all of the rest values are very close to 1, right, which is a convenient number. And the stress values in this patient are, upwards of 2, almost 3 here, or 3 here. A normal heart, like if you ran for the bus for 2 minutes, right, and you really ran for it, your heart, your demand would probably go up to about close to 5, right, mils per gram per minute. So it's quite a dynamic range, right? And you don't even notice, other than the fact you have to breathe to exchange oxygen and everything, but okay. Just to look back at the nuclear medicine technical stuff that we looked at, remember we talked about this attenuation correction. If you don't do attenuation correction, this data turns into this data, right? Which is a remarkable difference, right? Because now it looks like both stress and rest are abnormal, right? And the reason this looks abnormal is because the photons coming from this region in the heart had to get through a lot more tissue, right? And so they looked like there were fewer coming from that region, but really it wasn't the source. It was the fact that the occluding objects in the projections we took made it look like there were fewer photons there. And so it's quite important to do this attenuation correction in order to get this right, which requires a CT scan usually. So you have a CT scanner strapped to your nuclear medicine scanner, right? You do the CT quickly, and then you do the nuclear medicine scan. Ironically, if you just looked at the CT, you could call a lot of things just based on the CT, which we'll see as this evolves, and we'll look at. The news looks really good for nuclear medicine right now, right? And it is really good for people who are at the extremes of they're actually quite sick or they're quite normal. In the middle, it turns out this technique you may as well follow, right? So, well, we'll see that though as we go along. So to get our coordinates, right, you should have this coordinate system in your head. Let's start first by looking at the short axis. These are the 3 views of the myocardium where you're up towards the valve plane and you've organized yourself so that you're looking. Remember our bullet? We're looking up through the apex. So we'll cut away all of the heart except for the basal part. So except for this region right here, look at that, and that's this. Okay. And so we get 6 segments in that view. We move down towards the apex and look at the mid part of the heart, and we get 6 other segments, right? Same orientation. And then the apex down here. And then these views, the 4-chamber is a view that's cut through here such that you see the right ventricle on one side and the lateral wall on the other. It's the lateral wall, right ventricle septum. And then we're going to cut to the 2-chamber view, which is basically the orthogonal view to this one, right? So it's cuts down here, and then one that's right between the two is this, the long axis view. And you see the outflow tract of the aorta. All of these have the left atrium in and the mitral valve. But this one, you kind of cut through this way, and then up here you would have the aorta coming off of the left ventricle. So there's this one, this view is the 4-chamber, right? This view is the 2-chamber, and then this view is this long axis. Those 6 views are presented both in echocardiography, which we'll look at, or ultrasound, and in nuclear medicine, and also in CT and MR for that matter. They're like the classic views. So here's the labels for where those are. We talked about this ahead of time. So. And here's how you generate the stress image. And so we have 5 potential ways to generate a stress image here. You can put the patient on a bike. And with nuclear medicine, because the patient will glow for a long time, you can just get them to walk over the corner and get on a bike. Like, and they get on the bike for a little while and you inject the stuff. And then they walk back over to your scanner and get in and you scan it, because it takes a long time. There are other ways of doing it. If the person isn't a great cyclist, for example, for whatever reason, like they're not fit, right? You can put a drug into a line and perfuse them with that drug, and it will change the blood flow in their heart. 3 of them change the blood flow directly. Okay, so adenosine, which is a very old drug, it has a very short half-life. If you stop it, it just goes away. And it will basically open up the vascular control systems distal to the major vessels so that all of the little vessels open up. And it basically says, it thinks that you're exercising. So all those vessels open up and you get this flush, like the perfusion flush. Now, you can obviously generate side effects with something like this, right? Bronchospasm is a common side effect. So that when the lung vessels open up, the lungs, react to that. Heart block, that's not a good one, which is when the normal trajectory of the electrical activation from the atria down into the ventricle gets stopped. So it's called heart block. So you get the atria fire off, ventricle's going to fire, they never do, right? So then the backup system is the ventricle will just fire itself off, right? It won't sit there forever. It eventually says, nope, I got to fire, and then it'll just go on its own, right? Regadenoson. This actually is a cool drug in that it basically just affects the heart. And so it's unfortunately, it's a bit expensive, but it's really good at isolating, if somebody has, lung problems or something like that, you can use regadenoson. Dipyridamol also affects the whole body. It is a very good dilator. So it causes high flow. So normally you would do a baseline and then you start the drug, or the other way around, right? So stress, start the drug, measure your SPECT, and then turn the drug off. That's called rest now, and see if and then dobutamine is an interesting drug. It's like adrenaline. And so it doesn't necessarily open up the vessels directly through some drug or hormonal response. What it does is it increases the contractility of the heart a lot. And so this is what happens when you're scared. So if all of a sudden something really scares you and your heart starts pounding in your chest, that's adrenaline, and you can make that happen with this drug. And so it doesn't necessarily change the perfusion, but it does change the load. So the heart is working really hard, and it can run out of gas just from all that work, right? So what's really interesting is if you're doing dobutamine and you ask if a patient can hold their breath, with exercise, you can imagine that it gets hard to ask a patient to hold their breath, right? So if you're exercising, say, in an MRI scanner and some kind of scanner, they hold your breath for 10 seconds and they've been pumping the bicycle, that's going to be tricky. This, their heart's pounding away. You ask them to hold their breath, and they can hold it for a long time because they're not breathing heavily. The only thing that's really working is their heart, not their legs. And so it's an interesting form of stress. So here are how the protocol is done. You either infuse the drug at a constant rate into the patient through an IV, right? Regadenoson looks like you put a bolus in, diprotamol and dobutamine, you both infuse. And dobutamine has this interesting thing that you start at a low amount. So you set your perfusion machine to put in a low amount of dobutamine, and then you ramp it up and see how the patient reacts. And then as their heart rate hits a specific level, then you say, okay, we'll shoot at that level. So here's normal perfusion, where, so basically the stress electrocardiography was equivocal. So they put them on a treadmill, put the ECG leads on, couldn't decide yes or no whether or not the ECG changed. And sometimes this, basically you can have heart disease and this won't change, right? So it's not a very sensitive or specific test, it turns out. If you have a STEMI, yeah, who cares? I mean, you just go to the cath lab, but for somebody who's stable, doesn't matter. Invasive, this person already had coronary angiography, so we already got really high resolution pictures. There's a 30% lesion in their LAD, a 50% lesion in their RCA. That's probably RCA back there. And here, when we do the stress and rest with the nuclear medicine, it looks like this person is normal, right? So they don't have a perfusion deficit. And it's fairly clear on this image. I mean, it doesn't look like there's anything weird going on, that they're normal, right? And here's remember, this is the raw data from which those images are obtained. Here's the heart up here. So it's in a pretty good spot, right? It's pretty isolated in terms of the slices you're gonna make 3D images with. Here is that same patient. When you bin the images, so you're taking an EKG all the time that you're making these pictures, right? So then we'll just take the raw data and we'll put it into, say, 10 bins. And those bins will be fractional parts of the R to R on the EKG. Excuse me, I'm gonna cough or so. And then you play those back. So you've got 0 to 10, 10 to 20, 20 to 30, play them back. And this is the set of pictures that you get, right? It's kind of cool. When the myocardium gets thin, the counts go down because it's sort of maybe like an 8 millimeter thin strip of muscle. And then when it goes down to end systole, the myocardium is quite thick, everything's collected together, the counts go up, right? For that location. And then you can put this model back together. It's a very low resolution model, but you can make something that, gives you an idea of the left ventricular function of this patient. And it looks pretty normal, right? So this patient, you'd say normal. I'm not sure how often this is actually done though, because it doesn't usually look as good as this, because you're using 1/10 of the data to make these pictures, right? Here's an example of where we are in high quality imaging, right, versus SPECT. And this is a CT scan in a patient in which you can see there's a nasty little sort of soft plaque right here and closing this vessel down to probably 50% of its diameter, if not 75. And then there's another nasty lesion down here. This is the patient's right coronary artery. However, in this patient, when you look at the rest stress, it looks pretty normal, right? And so this goes back to what I was talking about before. When you're sitting there as a person that can get one of these scans, no problem. Like this thing costs $500 or something. and you see this, what do you do? And so if you don't have symptoms and this thing shows up normal, it's probably best just to go on a statin and just live with it, right? In the early days of coronary CTA, which is what this is, these were all getting called positive. And a lot of these patients went to the cath lab based on their CT. When they got to the cath lab, the cardiologist was like, well, we're not going to treat this. And so you just did a cath, you didn't put a stent in, and it's kind of a waste of time, right? So this is what's inducible ischemia. And so we have stress. So we say we use dipyridamol or adenosine. We measure the nuclear medicine scan. It looks like this in the long axis. The bullseye, remember, this is the apex. This is the lateral wall, septum, anterior wall. This is big purple hole here of relative flow. So they have some kind of apical stress-induced abnormality. After you let them rest for a while, it recovers. So this is ischemia, which is induced by the stress, but then recovers, okay? And so it's less severe than ischemia that would not recover. And then here we see, oh, are we out of time? Sorry. Oh, we're out of time. Sorry. We're going to do one more thing. This stress rest. So what's different about this case? During stress, we get this inducible ischemia. During rest, we get this ischemia. And so that's called a fixed defect. And in the imaging, you look at that and you say, this tissue here is likely dead, right? It's likely an infarct that happened quite some time ago, and it's probably scar tissue. And it's just not taking up this contrast agent because it's not myocardial. Okay, so I'm going to stop right there, and I'll get this movie going. Okay. And I think we have to clear out of this classroom. So if you have any questions about the stuff today, just shoot me an email and I will post those questions up, right, in the announcements and stuff like that if it's a question for everyone. And then we'll continue on with nuclear medicine on Thursday, look at some cancer, and I'll do a presentation, an example presentation. Okay.